for today's webinar, where we'll discuss findings from the report exploring low-income Californians' needs and preferences for behavioral health care, and hear how behavioral health care can be better integrated into primary care settings. We had a terrific response to this webinar, which I think indicates the high level of interest and momentum in the field right now. I'm Rachel Wick, Program Officer at Blue Shield of California Foundation, and joining me today I have Elizabeth Morrison and Mary Rainwater, who are consultants with Blue Shield of California Foundation. They are two of the foremothers of behavioral health integration in California and bring extensive experience working in this field, both from the direct service provider and program design perspective. They are also currently co-leading the learning community for our foundation's Behavioral Health Safety Net Integration Initiative, and have been amazing teachers and mentors to me as we have developed this new body of work at our foundation. Elizabeth will present some strategies for providers to respond to the findings in the survey, and Mary will join us at the end of the presentation as we answer any questions you may have. We also have Holly Hughes, Behavioral Health Director for Santa Cruz Community Health Centers, an FQHC with 2 primary care clinics in North Santa Cruz County. Holly's Health Center launched its behavioral health integration work just over 2 years ago, so she will be sharing her center's real-world, real-time experience in integration. Before we start, I want to note that if you have any questions during the presentation, please type them in the question window. We will do our best to address your questions during the Q&A session taking place at the end of the presentation. Historically, we know a significant number of patients did not have access to adequate behavioral health care services, and this has been especially true for low-income patients. These services were not funded properly, and they were often operated separately. Thanks to the Affordable Care Act and a changing healthcare landscape, there are now more opportunities than ever to improve, expand, and integrate behavioral health services in California and across the country. Today's discussion is part of the Foundation's continuing work to evolve the conversation on behavioral health as we bring together community stakeholders to develop integrated systems of care for low-income Californians. One of the things that stood out to us as we were developing our initiative was the absence of patient voices and experiences in conversations about behavioral health integration. And since this work requires significant cultural change for both primary care and behavioral health providers, we think patient voices are critical. And so we decided to add a set of questions focused on behavioral health to an existing patient experience survey that we conducted with Gary Langer and Associates. This is a well-known body of work that the Foundation has engaged in over the last several years. And so we decided to really integrate the behavioral health focus into it. We asked 1,000 low-income Californians about their perspectives on behavioral health to help safety net providers better understand the needs and preferences of their patients. And I just want to note that the survey primarily looks at integrating behavioral health into primary care. I acknowledge that there is a larger conversation in the field about integrating primary care into behavioral health that won't be captured in the results that we share today, but is equally important work. So these are the questions we sought to answer with our research. Most importantly, what was the need? And we mentioned here, that, did you have a behavioral health issue in the past year, but we didn't use that term with patients. So what we asked patients about was, had they experienced stress, emotional issues, drug or alcohol use, marital or family issues, or just feeling down about things, to really gauge what their need for behavioral health services was. We also wanted to find out what behavioral health services were available to them or perceived to be available to them in primary care, what was their experience in receiving these services, and most importantly, what did patients want? And here's what we found. First of all, 1/3 of those surveyed said they needed to talk about a behavioral health issue. And so I think it's really important for health centers to think about the number of patients that they're serving and what it would mean if 1/3 of those patients had a behavioral health need. And how many of those patients are actually getting services at your clinic right now, behavioral health services. So of those who said that they had a need, only half indicated that they actually spoke with someone about it. And so that, again, is another opportunity that we're going to focus on. Of those who said they wanted to talk with a healthcare professional about behavioral health concerns, two things I want to point out on this slide. The first is who's at the top. Patients with chronic conditions, those who visited the doctor 6 or more times, and those who rated their health not good or poor are among those who were more apt to have wanted to speak with a healthcare provider about behavioral health. There's huge movement in the field right now in addressing patients with complex chronic conditions. And I think this slide speaks to the importance of integrating behavioral health in those patients' care especially, and a great opportunity for providers to focus on these patients. And another area of focus is at the bottom of the slide, and where we see the percent of people of color who wanted to speak with a professional about behavioral health was relatively low compared to other groups. And I think we need to note that this is not a reflection of a lack of need. It's about willingness to speak with someone. And we know there are issues of stigma in communities of color, and it's critical that we deliver culturally responsive care and communication for these patients in particular. We have to open the door and open the dialogue for them. Barriers to seeking help. Among those who needed to speak with someone but didn't, 6 in 10 said they didn't know who to talk to. This suggests that providers should ensure that they're making patients aware that help is available and how they can obtain it. So even if you have behavioral health services at your clinic, do patients know you do? And can they get access to them? They also indicated that they don't necessarily feel comfortable talking with providers about these issues. And again, I think here we need specific strategies for creating a culture in which patients are more comfortable seeking services and supports. And Elizabeth is going to talk more about this in her remarks. And this is the opportunity that we have in front of us to close the gap between what patients want, what's highly important to them, and what's currently available. And so we see across the board substance use, mental health counseling, social service referrals. Patients' desire and belief that these services are important outweighs their availability in health centers. And so for us, closing that gap is a key priority and an opportunity area. This gives you a sense of how community health centers compare to other provider types in terms of availability. So you can look, for example, at how your community health center, how the community health center world compares to Kaiser or to those in private practices. Again, we're seeing opportunity, I think, across the board to really improve access to services. Now, when it comes to where patients want to receive behavioral health services, we find that many people want to get them where they already receive care. And so about half who have seen a counselor saw them in the primary care setting. Over half want to see them in that setting in the future. And so I think, again, responding to what patients want and where they want it is critical. And to summarize the findings, 1, a broad gap exists between the need for behavioral health services and access to treatment for patients. Patient interest in receiving behavioral health services far exceeds current availability. Primary care providers and really the whole healthcare team can do a better job of creating a culture, a comfortable culture for patients in seeking services and asking about stress, anxiety, and emotional issues. And finally, patients who have behavioral health services experience higher levels of connectedness and continuity, which in turn enhance patient satisfaction. And I think there's a broad movement taking place for community health centers wanting to become providers of choice in the post-ACA environment. And I think this shows us that offering behavioral health services is a key part of building patient satisfaction, patient loyalty, and really patient engagement in care. And now I'd like to go ahead and turn it over to Elizabeth and Holly to discuss how health centers can really respond to these findings and work to close the treatment gap by integrating behavioral health and primary care. And as a reminder, if you have any questions, please type them in the question window and we'll answer during the Q&A. Take it away, Elizabeth and Holly.
Thank you so much, Rachel, thank you so much for your talk. I actually just clicked on the slides and I'm back at the beginning, so I seem to not have gotten to my slides. So maybe one of the, oh, great, thank you. Thanks so much. My name is Elizabeth Morrison. I'm really happy to be on the webinar today. I really appreciated, Rachel, your summary of the Langer findings, which I think are super exciting to all of us in the field, straight from the patient voice. So we're really excited about that, and I'm going to talk really briefly. I'm going to go through just 10 things that are related to the Langer findings and in general related to the longevity of the integrated behavioral health field. I know when I looked at the organizations who were signed up on the webinar that I recognize lots and lots of organizations that have moved forward in integrating behavioral health into primary care. Some of you guys have been doing it for a really long time, and so I just want to put out there that some of these things that I'm going to talk about, for sure many of you are considering and have moved on, and they're sort of already on your radar, and I appreciate that piece. So the first one that I just wanted to comment on is about us looking at the ratio of behavioral health providers to primary care providers in the primary care setting. Or the other way to look at it is the ratio of behavioral health providers to the total number of patients. Certainly when the integrated behavioral health field really took hold a decade or so ago, we were looking at ratios of 1 behavioral health provider to 7, 8, 9 primary care providers, which is about 15,000 patients. And as we can see in the need from the Langer survey and of course from all of the secondary data sources, we know that the ratios really need to look more like 1 behavioral health clinician to 2 PCPs. And you know, sort of the radicals, I think, like myself, think that we would even look at 1 to 1. And so the first one is just to consider what is the actual need and what ratios do we actually need for sufficient integration. The number 2 is ensuring organizational leadership support. Sometimes we talk about this as organizational leadership parity. So we certainly can hire behavioral health clinicians and have them work in primary care centers without significant leadership changes. Behavioral health directors and behavioral health on executive leadership, it's very difficult to really change the culture around whole person care. And Holly is actually going to talk about this one. So I'm going to leave the rest to her and move on to number 3. Increasing pathways to behavioral health services. For some of us in the early years of integrated behavioral health, we had the primary care provider acting as somewhat of a gatekeeper, that they were really the referral source for integrated behavioral health clinicians. And even in the Langer work, they focused on the primary care provider as the doorway in, and it's a very, very important doorway in. And there being no wrong door into integrated behavioral health services really ensures that patients have a much higher chance of getting the services that they want and need. So looking at staff being able to refer to behavioral health, looking at patients being able to self-refer, et cetera. And Holly's going to talk about this one, so I'm going to leave that one. And number 4, create an open communication and active promotion of behavioral health services. So really, it means letting everybody know that you're open for business for behavioral health. And this means all kinds of clues to your patient population, to our patient population, that behavioral health is here and available, and that those conversations are welcome and invited. So there are many ways to do this, from behavioral health screening tools, which certainly indicate that the healthcare team wants to know about behavioral health concerns, to having the behavioral health clinicians' names on the doors, to having posters in the waiting room, and the video loops in the waiting room indicating information about depression or anxiety, or making sure that the waiting room in particular and the staff and the health center as a whole really is inviting and letting patients know that we want to hear about your behavioral health concerns. Embedding behavioral health in the healthcare team. This is, we thought, I think behavioral health in some ways was thought of as a specialty referral, even in integration. And that really has to do in some ways with number 1, that many of us don't have sufficient ratios. So we might have 4 behavioral health providers and 50,000 patients. And so if we don't really have the ratios, then it does sort of become a specialty referral. We start to sort of triage for those that are the very highest need and refer them. And really, I think in terms of whole person care and in terms of team care, what we'd like to move toward is having behavioral health providers embedded in the healthcare team, so that that expertise and availability is there for all patients. And certainly this matches with the percentages of, as shown in Langer, of people who want and or need, and those two things are closely related, behavioral health, and also just the data that 70% of primary care visits are psychosocial related. So when we look at this type of data, it really looks like every patient ideally would have some opportunity to have contact with a behavioral health provider, and that they would be embedded on the team. Increasing primary care providers' capacity to manage psychotropic meds. Now, I know that many of you are already working terribly hard at this. This is a really complicated issue, and this is just really a nod toward moving away from solely face-to-face visits for our psychiatric professionals, and I know many people on the call are already doing this, and simply the shortage is just too severe, and that our primary care providers over the years, many of whom have gotten increasingly skilled and willing to manage complex psychiatric illness, and that this really is the direction in the future, that to have psychiatrists and psychiatric nurse practitioners in our facilities and coaching and helping our primary care providers become increasingly willing and able to manage psychotropic medications. Increasing capacity for substance use intervention. This, of course, is always a hot topic in the field, and a really complex one. And many organizations on this call have really gone the direction of integrating substance abuse, which is really impressive. And there's really, I think, a case to be made for integration for behavioral health professionals. And that means for behavioral health professionals that we already have in our systems to become increasingly skilled and knowledgeable about substance use intervention, so that we're not splitting those two things, substance abuse experts over here and mental health experts over here. But instead, one of the things we can do to increase capacity right now, even with all the billing complexities and the workforce complexities, is to have our behavioral health clinicians obtain certifications and specialty continuing education to really increase their capacity to do assessments for substance abuse and feel confident in providing a particular level of treatment for sure. And number 8, enhancing evidence-based communication skills. This is really about the culture change that comes with integrating behavioral health, that ultimately it is it's more than just hiring behavioral health clinicians and adding that particular service into a traditional medical clinic, like adding a podiatrist, for example. It's really about a change in culture towards whole person care. And part of that change in culture, part of one of the really important pieces of this, is to enhance the communication skill of our staff members so that they are feeling more confident and more comfortable in conveying empathy, that our providers are increasingly skilled in motivational interviewing and other behavior change strategies that are based in connecting with patients and the therapeutic alliance and conveying empathy, so that the entire system increasingly becomes more skilled in partnering and connecting with patients. And number 9, providing culturally sensitive, linguistically capable care. Of course, this isn't news to anybody or brand new in any way, just a real nod to the diversity of California and the importance in when we're able to hire staff and providers that are reflective of the community that we're serving, and to make sure to have really high quality interpretation and translation services available, and to really broaden our idea of what culturally sensitive or culturally responsive care is. That for sure the diversity of ethnicity in California, we think of ethnicity, and to also think about LGBT populations and different age populations, and as a larger philosophy about responsiveness and curiosity about the patients that we serve and how to meet them and engage them where they're at. And the last one, and Holly's actually going to talk about this one next, so I'm going to also leave this one really short, the importance of identifying and measuring population-based data. And I'm going to turn it over to Holly.
Thanks, Elizabeth. So at Santa Cruz Community Health Centers, we have been committed to integrated behavioral health since 2012, so it's been a relatively short period of time, considering how long this has been an important topic. And in that period of time, though, we've had quite a bit of success that I wanted to share. We've had 400% increase in behavioral health visits. We've hired 6 behavioral health providers and 1 behavioral health medical assistant and 1 health educator who is part of our team. And so that rapid growth and the increase in access to behavioral health within our clinic has resulted in some curiosity about what it is that we're doing to be so successful. And so with that in mind, I wanted to just focus on 3 of the topics that Elizabeth identified. This first one, ensuring organizational leadership support. It's important to have behavioral health leadership representation at the executive level for many reasons. I've put here on the slide just an example of our leadership team roles. And as you can see, there is behavioral health representation at the table. We made that decision early on. Leslie Connor, our executive director, promoted me after about 6 months of us committing to integrated behavioral health, and some of that was influenced by the mentorship that we got from Elizabeth Morrison, who you just heard from. And for our organization, that's really made a big difference in how quickly we've been able to grow the department. Oh, let's see. And then you'll also see there that there's a couple of points about just the when you commit to having behavioral health representation at a higher level, it really says a lot about the way the organization values behavioral health. Brings it to a new level. And then these points aren't on the slide, but I wanted to just share some observations that I've made about some potential errors or pitfalls that can happen on this journey. One of the things that I've seen, and I saw it in our organization early on, but we quickly addressed it, was just not seeing the value of behavioral health leadership. It's not really a purposeful experience that happens, but there's just a lack of awareness around the importance of having a clinical lead when you're trying to increase your behavioral health services for patients. So just like you would consider a medical director being a hugely important role in the organization, it's of equal importance if you're going to embrace full integration to have behavioral health director to have that role be valued as well. I've seen some organizations have a setup where there's a non-clinical administrator overseeing the behavioral health department, and that doesn't really make sense for long. It doesn't make sense if you think about it in the medical world. You know, you definitely need that medical director making some clinical decisions along the way, and similarly you would want that behavioral health leadership in place. And then we did for a while, and I've seen other organizations set it up where the chief medical officer or the medical director oversees the behavioral health department. And that also, things start to emerge where that setup doesn't really make sense either. They're two very different disciplines. And so it makes the most sense, I think, to have equity in the leadership representation. Something else I've seen as a bit of an error to avoid is administrative leadership making the decision to ramp up behavioral health services and wait to have leadership put in place, clinical leadership put in place. And in that case, I've seen there's a little bit of risk in losing quality clinicians. Behavioral health providers are used to having clinical leads in their organization, unless they're in some kind of setup like private practice. But if they don't have that, it can feel discouraging to them, and sometimes they won't stick around. And it's also helpful to think about retaining the quality, skilled behavioral health leaders that you have. And if you don't have a leadership pathway available within your organization, you may lose them to other positions. And then one other just observation that I've made, I was just at a conference last week, and I heard one of the, it was probably a medical director asking some questions about how to design the behavioral health services for his organization. And I could tell by the questions he was asking that he was being influenced by behavioral health providers who were coming from, they were embracing more of a traditional therapy paradigm. So if you're starting to hear things like we can't be interrupted, or the intakes need to be longer than our returns, or I can't possibly see more than 6 or 8 people in one shift, or 30 minutes isn't long enough, those are indicators that you may be needing to seek out clinicians who are a little better fit for the primary care setting. And in my experience, I've practiced both models for an extensive period of time, enough to know for me and from patient report and experience that there's really nothing any less meaningful about a 30-minute therapy encounter than a 50-minute one. So there really is a lot of value foundation to this model, and if you have a leader that can really drive that, it can be very helpful. If you have someone who believes in it, and then they can hire for a fit. And then the leader is just a piece of it, because then there's also, of course, the actual behavioral health providers, the staff who, like, I can't say enough about my team. They're so enthusiastic and flexible, and they're actually pretty naturally committed to the 30-minute sessions and the high productivity, because they're so aware of this great need. And so the patient care itself is what drives them to be so enthusiastic about the model. This next topic, increasing the pathways to behavioral health services, is an important one. We, in our clinics, have eliminated the term referral when it comes to behavioral health services, just like a front office staff would never say that a patient needs a referral to their PCP. We're working hard to train everybody in all the departments to think similarly with behavioral health. It is a culture change, because I think a lot of times people think that it is a specialty service and they don't feel as comfortable, but the more we encourage it and the more they see the patients responding well, the easier it becomes. This idea of no wrong door, I have permission from one of my patients to share a story. So she's a person who, in her late 20s, she walked into our clinic after trying to find some help at the county buildings. She literally got lost walking around the buildings, couldn't find the right building, and then she did and couldn't find the right door, and then when she found the right door, there was nobody manning the desk, and so she got discouraged and left, and she came to our clinic instead. And then she had just become stable after a really severe manic episode where she was found on a really big bridge in a major city trying to jump. She was admitted to inpatient psychiatric care and in that city, and then when she became stable and was released, she decided to move to Santa Cruz to be with her family. So she was about to run out of her medication, and she walked into our clinic. And if our front office staff person had not conceptualized that as behavioral health being the first line of service, she would not have been seen that day, because there were access issues, so she would have been turned away. And what happened instead was that our front office let me know that she was there. I met her in the waiting room. I was able to have an appointment with her that day. And then the next day she saw one of our physician assistants, and he prescribed the medication that she needed. He was comfortable doing that because she had documents from the hospital, and he knew that I would be evaluating her on an ongoing basis. And within about 2 or 3 months, she engaged in treatment with both of us. And after about 2 or 3 months, she no longer wanted to come in for therapy services. She was working a lot and really stable, and she gave us both the feedback that she had never received such quality therapy before, and she'd had quite a bit of experience with that. She also said she felt like we were real. She felt like we cared. She felt respected and listened to. And I realized that we have so many patients who are stuck in their abyss of suffering, and it doesn't always turn out this way. But I wanted to share this because it really was such a high risk. You know, part of her severe manic symptoms, there was some command hallucinations. So if she hadn't gotten the medication she needed, she really could have had some harm going on there. So our front office staff having that open door was really important to her and to our organization. And then finally, this last slide about population data. the slide that Rachel talked about really stands out to me. The comorbidities seem to be such an obvious indicator of how important it is to address the physical health and the behavioral and social emotional simultaneously. So we're still at a place in our organization where we're building our outside relationships, and we're working really hard to address our internal system struggles so that we can provide better care for our most vulnerable patients. I'm sure many of you can relate to that. It's quite a process. And I would say that one thing that's emerging that feels really clear and consistent is that we are embracing a team approach, and this is often led by the behavioral health providers or MSWs when it comes to the more vulnerable, complex patients, and it's really had a big impact on the patients and on the care that we provide. So I'm really excited to be a part of all these changes, and I appreciate the opportunity to share these examples of our work with you all, and I'm going to turn it back over to Rachel, and I look forward to answering any questions that you may have.
Holly, thank you so much. I think that was such a rich presentation, both including, the real patient's experience, as well as your health center's efforts to really ramp up its behavioral health integration work. And I think, Elizabeth, thank you too for setting up Holly so nicely and giving folks a real range of strategies to respond to the Langer findings. We're now going to just open it up for questions. And as a reminder, if you would like to ask a question, please do so by typing it into the question window on your screen, and we'll read the questions aloud. We did receive a comment from one of the participants, which was about our use of the term community health center. And we used this term broadly, but it's meant to be inclusive of all providers of services to low-income patients, other free clinics, rural clinics, all primary care providers that are out there serving this population. Okay, a question just came in that I'm going to target to Elizabeth first and then Holly as well to chime in. The question is, what is the economic model for behavioral health? If we need more behavioral health providers in a practice, who will pay for it? Is it reimbursable? What about practices who say they can't afford it? So Elizabeth, do you want to start? And then Holly, maybe you can speak to Santa Cruz's experience here.
That would be great. This is Elizabeth. I was going to let me say a couple things about it, and I had the same thought that I know Holly had an experience in her health center around the financial modeling that was really significant. So let me pass it on to her. The first thing I want to say is it is a really complicated question, and all of the providers, I imagine, on the phone have very different billing structures, and then throw onto that our entire kind of economic way of being paid is so changing so rapidly that I certainly want to take a shot at answering this, and I also just want to acknowledge that it may not be accurate or fit for everybody on the call, and that is that behavioral health is billable. So there's multiple provider types that are billable, and for those of us who have a PPS rate, which is not all of us, it can and should be profitable, and many organizations have figured out the cost modeling around this. Even with just the managed Medi-Cal plans administrators, behavioral health administrators, for those of us who aren't able to get the PPS rate, there are certainly ways to make this cost neutral. But with the PPS rate, even for those of us who might have a really low PPS rate, it's absolutely financially sustainable. There's no doubt about that. And so I would be totally happy to chat with anybody about this if they want to call or email me. Even though, like I said, I know this doesn't apply to everyone, but by and large, it is financially sustainable. So Holly, did you want to talk a little bit about your experience?
Sure. I think it's largely driven by the billing structure. As you mentioned, we are an FQHC, and so we have a PPS rate, and our encounters are reimbursed at the same rate as the medical provider encounters. And so, we are able to generate quite a bit of revenue, and then we're small enough as an organization that we've tried to be creative in conceptualizing the funding, and so that's how we were able to hire and support the position of a medical assistant, and then the health educator also is being supported by our budget. And we commit to a productivity level of 9 billable encounters per 8-hour shift. We schedule 12, and sometimes we see 12 in addition to a step-in, a warm handoff or 2, and other days we might see 7 or 8, but we shoot for 9.
I wanted to really encourage too, just to say one quick thing would really encourage anybody who hasn't run the numbers to run the numbers. Sometimes behavioral health services revenue and costs are not on the financial dashboards of the organization. They haven't been integrated into the financial modeling and the dashboards. And sometimes, I work with organizations that run the numbers and they say, oh my gosh, this is, we're hemorrhaging money. And typically when that happens, the productivity is very low, sometimes at 2 or 3 a day, or you have an organization like Holly's where they hadn't run the numbers, and when they did, they were so pleasantly surprised. It was, woohoo, they found out that behavioral health was incredibly profitable. So that's just a push to run the data on that.
Thank you both. We have another question about the staff. Holly, directed to you about who you hired, what type level of staff they are. Maybe you can tell us some about what you looked for in terms of qualifications and competencies in the staff.
Sure. Mostly we're looking for fit. People who are really wanting to serve our patients. That's obviously the number one piece. And then for the behavioral health provider positions, we're hiring licensed providers, so mostly LCSWs, and we do have one soon to be licensed marriage and family therapist, and then we have one associate clinical social worker who is working under supervision toward her license. And so mostly we're trying to have the balance of LCSWs, because the reimbursement rate is the highest for them. And then, like I was mentioning in the other answer, we're able to look at the entire budget and then support these other positions, because we've found such great people that it's been worth it to work the budget out in such a way that the people who are generating a little bit less revenue are still on our team. I think I answered all those questions.
Yes, that's terrific. Another question rolled in. If I think both of you, either of you, can comment on using outside referrals when health centers have behavioral health but capacity is limited. Do you have any recommendations or suggestions for folks who are still needing to use referral processes to refer outside their health center?
This is Elizabeth. I just want, go ahead, please.
Okay, this is Holly. I was just going to jump in on this because we feel really comfortable at this time supporting the patient in heading in whichever direction makes the most sense for them. And we're wanting to collect more official data on this, but anecdotally what we have found is if you sit with someone and you talk about what their options are outside our walls and inside our walls, a lot of the time once they've met with you and they know their medical provider and they have a good relationship with the clinic itself, they do opt to stay. But then, yes, if we have limited capacity or access, or if the person really identifies that they want a more traditional therapy model, we help them. We do kind of a warm handoff idea, even though it's not face-to-face, within the private practice therapists in our community, a lot of the other agencies that are set up to see people for therapy services. We encourage patients connecting with those services.
Yeah, I just wanted to say something quickly about Blue Shield Foundation of California, who's in the middle of a community integration grant period. And I think there will always, I think, be a need for referrals to different places in the community based on patient preference and where they feel most comfortable being treated, and sometimes capacity, although hopefully referrals due to limited capacity hopefully won't be the primary reason, only because hopefully we're all increasing our capacity as much as we can to be able to treat patients where they feel most comfortable and where they would prefer to be treated. But there will probably always be a need for referrals, and so for that reason, I think the work that Blue Shield's done, and many of you have done in your communities even before or during or after any grant making period, around just really working on the relationships in the community and figuring out how to make the patient experience of moving between organizations and sharing information between organizations, which is a tough one, to continue to do that heavy lifting to help with continuity for patients when they are referred.
Thank you both. I love kind of your perspective on patient choice and experience and really facilitating that for the patient, because I think that, again, is keeping the patient at the center. So wherever they're comfortable seeking services, whether it be inside the walls of the health center, which we know we can do a better job of, or going outside of the center, we want patients to have choice and to get access to the services they want where they want them. Question came in about, I think for Holly, can you expand a bit more on what you called the 30-minute model?
Sure. A lot of the primary care clinics who are embracing integrated behavioral health are using a 30-minute therapy encounter in their templates. Those are the scheduled appointments versus the more traditional 50-minute time slot with maybe sometimes a 90-minute intake are what some people are used to, both patients and clinicians. And I can't say enough about this. It's hard for me to know where to start just because I've had experience in both, and I've been really pleasantly surprised about how it's changed my clinical skills. It's honed my clinical skills. The encounters have become more focused. There's a lot less emphasis on the process of kind of taking care of assuming that the patient might need processing around the process. Those of you who are behavioral health clinicians will understand what I'm saying. Instead of just sitting down and opening up to exactly what needs to be focused on, I found that I stopped noting, oh, we only have about this much time. I stopped assuming that people needed 5 or 10 minutes to shift out of the therapy session. You know, there's just a lot of positive changes that have happened with the 30-minute sessions. And of course, I acknowledge the challenges that we all face in our healthcare system with these shorter visits. I think if you don't combine access with these new approaches, it's really challenging. So it's important that we develop systems and operations that allow patients to come in more frequently or as frequently as they want to come in theory, you know, ideally, if we're going to have these adjusted sessions. But I think the model has been really positive, and all of our behavioral health providers on our team really like it and prefer it to the more traditional model.
Thank you. We have a kind of a systems question, which I'm going to ask Mary to chime in on. Can you comment on the bifurcation of mild to moderate versus moderate to severe for Medi-Cal members? So for folks on the phone, the way our financing is set up in California splits the population and the delivery of services to those populations. But Mary, can you talk about that?
I wonder if she doesn't know. She's muted.
Mary, are you muted?
Oh, did I unmute?
Yeah, now you are.
Oh, and that's all I have to say about that.
Thank you. That was wonderful.
So what you missed me say is just how great the presentation has been. But I think, as you pointed out, Rachel, in talking about the question itself, it's really a product of the siloed history of funding between the specialty behavioral health, mental health system in California and in many states, and the primary care system. So, fortunately, that has been eradicated a little bit with the Medicaid expansion this year, but I still think it points to a comment that you made earlier, Elizabeth, as well, and Holly touched on, which is the importance of thinking about your system more broadly than just what's within your four walls, which is some of the important work that is going on in the initiative that we're working with Blue Shield on, which is really that there has to be shared vision and a development of shared accountability across the various stakeholder providers in the community around how to work with the population, particularly now that the Medicaid expansion has made it possible. It may not be fully implemented yet, but it's possible for somebody with Medi-Cal managed care to go in any number of settings. So we're not there yet, and I think it takes a lot of work in the community provider level to sort of define how the population is best served. And again, keeping at the forefront the patient experience and desires as you do the planning.
Mm-hmm. And I think the comment folks made about understanding and looking at population health management. So for all the clinics and health centers to understand who you're serving, and Elizabeth has worked with health centers on kind of how do you look at your data to understand what populations you're serving and what's the need. Because even though our system has been set up to split those populations in two different places, in reality, we know it's much more complicated than that. So I think for all health centers, run your data and understand who you're serving within your four walls, as well as what's happening in your broader community. How are you connecting with your specialty mental health system? Another question came in, I think I'll direct this one to Holly, which is how do you initially engage primary care providers? And how do you start the conversation with the behavioral health team and management to move toward full integration? So what did it mean to reach out to, I think, primary care providers and physicians to get their buy-in as well as the exec leadership?
Well, I think this is a layered question. There's so many aspects to it, but I'll just share a little bit about how it happened in our setting. I was a provider, and I was practicing the more traditional model, and we had some collaboration going on. And what really spoke to our PCPs and our management, who are very patient-centered, was the need. I we had 6,000 patients total, and I was the only behavioral health provider, and the access spoke for itself. The patients really talked about the need, and I think that, and the providers, the medical providers, really wanted the support of behavioral health to address the social and emotional needs. So it wasn't really a hard sell within our organization, but I know in others it can be. So it's hard to strategize around, you know, what kind of conversations to have. But I would encourage people to use motivational interviewing techniques, really listen, you know, get the pulse on what people care about, and then you can usually find, you know, some kind of theme to continue to share so that people have a buy-in with this.
Thanks, Holly. Another question has come in. Elizabeth, maybe this one, you could take this one. Complex care coordination is an activity that's often overlooked. And Holly, too, I guess. In your model, is complex care coordination not the same as case management being provided on site by your staff or at the plan level? So the question here, maybe Holly, if you could start, where is complex care coordination part of your model, and or is it provided through the plan?
As I mentioned in my other piece, in our organization, we are heading toward developing a system for complex care. So it's definitely part of our priorities and in our values and in our mission, and we're just not quite there yet with the details of exactly how it's going to look.
And Elizabeth, do you have any experience in that area that you would want to share for folks that are interested in that?
I do. I still see patients in an integrated setting, but I also came from the community clinic world where I did that work for a long time. And I really appreciate the question. It's a really important question, and it is often overlooked. So I want to acknowledge that to the questioner. I think, you know, I think the in your model part of this was, you know, directed toward Holly, and I think I just want to take the opportunity to say, you know, just to sort of make clear that there really isn't, you know, a single model at all. There are some strategies that have promise and evidence behind them, and then the rest of it is sort of, you know, the commitment towards this whole person care integration, and then really figuring out what organically works for each organization and each population and each community. And complex care coordination, I think, again, just to go back to the patient experience and what we know about where our patients actually prefer to have that service and where it is most functional, that it's important to ask those questions as opposed to build systems where the patients are at. So complex care coordination, where the patient is receiving the majority of their care, as opposed to, for example, from, you know, not that it being provided by the health plan is always a bad idea or anything like that, but there is something about having the coordinator actually on the team where the patient is receiving the majority of their care and being able to work closely with that particular health team. And so I think it's just really important to look at where the patient actually spends most of their time in services and provide it there.
Thank you. Well, it looks like we're at time. I want to thank everyone on the call for joining us today and for your interest and commitment in delivering enhanced behavioral health care for low-income Californians. And I look forward to continuing the conversation with all of you as we move this work forward in California. A recording and slides from today's presentation, as well as answers to any questions that we weren't able to get to, contact information for the presenters today, and a host of other resources related to this work will be available on our foundation's website, blueshieldcafoundation.org. We will send an email out with links to these resources. And in addition, I want to highlight that we have a webinar posted on our first Langer report, Delivering on a Promise, advances and opportunities in healthcare for low-income Californians, and to encourage you all to check out that report as well. It has a lot of connection to the conversation that we had here today. So again, I want to thank you so much and look forward to connecting with all of you as we carry the behavioral health integration work forward. Thank you.